So we are going to talk today about the cancer predisposing syndromes that are associated to brain tumors. This is a very delicate subject because patients who are affected by a cancer predisposition syndrome, they have a sort of sword of Damocles pending on their head, and this is a delicate subject not only from the medical point of view, but also from the ethical and psychosocial point of view. So when do we have to suspect a pediatric cancer predisposition syndrome? First of all, we have to consider the family history and look at the number of individuals with cancer in that particular family. We have to consider the age at diagnosis of each cancer, and we have to look at the inheritance pattern of the disease. Then we also have to look at the patient-specific factors. Like, for example, we have to see if the specific cancer is commonly associated with the cancer predisposition, like, for example, in retinoblastoma. We have to look at the eventual possible constellation of multiple rare findings like dysmorphic feature or malformations. We have to see if we have multifocal or bilateral tumors or multiple primary tumors. And we also have to consider the younger than expected age at diagnosis, like, for example, colorectal cancer in adolescents. So here I provide you with a short table just to mention the main syndromes that are associated with brain tumors. So first of all, the neurofibromatosis type 1, and I would say also all the other rhasopathies, which are associated with the occurrence of low-grade glioma. Neurofibromatosis type 2, associated to vestibular schwannoma and meningioma. And so on with tuberous sclerosis, Li-Fraumeni syndrome due to p53 mutation and associated to high-grade glioma and choroid plexus carcinoma mainly, but also other kind of brain tumors. Then we will spend a few words regarding the constitutional mismatch repair deficiency syndrome, the Gorlin syndrome, the Rhabdoid tumor predisposing syndrome. Then we have Turcot syndrome and von Hippel-Lindau. So here we have the Ras-MAP kinase signal pathway, which is a signaling pathway who is critically involved in process of cell proliferation, differentiation, motility, apoptosis, and senescence. And rhasopathies are these medical genetical disorders where a mutation of one of the gene encoding for one of the protein which are effector of this pathway when one of these mutations occur. So we can have among the rhasopathies, first of all, the neurofibromatosis type 1, the Noonan syndrome, Noonan with multiple lentigens, the Costello syndrome, and craniofaciocutaneous syndrome. So, neurofibromatosis type 1. It's an autosomal dominant disease due to mutation of NF1 gene on chromosome 17. 50% of the cases are due to de novo mutation, whereas the other 50% are inherited from one of the parents. It has a highly variable clinical expression, mainly due to the heterogeneity of the mutation. We just have to think that we have more than 1,000 different mutations that have been identified so far. But it has also been postulated that some genetic modifiers can play a role. So the clinical evolution is quite unpredictable, and no genotype-phenotype correlation is possible. The hallmark clinical features are mainly the café au lait macules, which are present in almost 90% of the patient, and they usually appear in the first 10 years of age of the patient. Then we have neurofibromas, freckling, optic glioma, hamartomas, bone lesions, and of course it helps us in the process of diagnosis if there is the presence of a first degree relative affected by the syndrome. But many physicians are now questioning whether is it time to change the neurofibromatosis 1 diagnostic criteria and introduce among the major criteria also all these clinical features that we commonly encounter in these patients, like, for example, juvenile xanthogranuloma, hypochromic maculas, the unidentified bright object in the central nervous system, the neurocognitive delay, and least but not last, other malignancies like rhabdomyosarcoma, malignant nerve sheath tumors, and so on. So here, some nice pictures of a mosaic neurofibromatosis, which is also a phenomenon which could occur, which is due to a mosaicism for the NF1 mutation at different embryonic time. And here we see the segmental distribution of the spots. NF1 patients are at increased risk to develop malignant tumors, as we said, so mainly low-grade glioma, but also malignant peripheral nerve sheath tumors, juvenile myelomonocytic leukemia, rhabdomyosarcoma, pheochromocytoma. The low-grade glioma can appear in around 15–20% of the NF1 patient, and they are mainly located in the optic pathway, but could also be located in the brainstem. Optic pathway glioma generally occur before the age of 7, and they are frequently indolent, and they rarely need to be treated. Here in this picture we see the result of a nice study where 826 patients underwent a screening with MRI in order to detect the presence of optic pathway glioma. And as we said, here we see that in 18% of patients an OPG was found, but only 15% of this 18% needed further treatment, which means that only 3% of the initial population at some point of his evolution underwent chemotherapy. So this raised to the question to screen or not to screen these patients for the presence of optic pathway glioma. The answer is yes, we have to screen this patient, but how? According to the guidelines published in 2007, these guidelines state that the greatest risk of developing optic pathway glioma is in young children. So children under 7 years should have an annual ophthalmological examination, but brain MRI screening for OPG is not indicated, as treatment is not required in the absence of progressive visual disturbance. Of course, this is an open controversy, with some physicians who are in favor of the ophthalmological examination and against the screening, against the MRI screening, with the argument that in any case, if we detect an OPG with the MRI, we are not necessarily going to treat this patient unless if they become symptomatic. On the other hand, physicians who are more in favor of an MRI screening, they said that it is sometimes very difficult to administer ophthalmological tests to very young children, especially when they are affected by neurocognitive, when they present neurocognitive impairment, like in this condition. So for the rare cases who become symptomatic and for whom we are going to administer some kind of treatment, the mainstay of the treatment is chemotherapy based on the Packer protocol, with 18 months of chemotherapy with an association of carboplatin and vincristine. When we compare optic pathway glioma who underwent chemotherapy and we compare the NF1 patient with the non-NF1 patient, we see that the event-free survival is higher for the NF1 patient, so it seems to be a good prognostic factor. But, of course, NF1 patients have also an increased risk of vasculopathies, like this Moya-Moya disease, and this is the reason why the NF1 patient should not be irradiated. Now we move to the constitutional mismatch repair deficiency syndrome. The mismatch repair machinery is responsible for the repair of DNA single base pair mismatches and small insertion or deletion, so it contributes to genome stability. A crucial role is played by the gene MLH1, MSH2, MSH6, and PMS2. We have to think that defects in this system, they increase the mutation rate and they lead to, they start the process of the oncogenesis. So when we have an heterozygous defect in one of the mismatch repair genes, in this case, we have the Lynch syndrome, which is characterized by the early onset of colorectal cancer. But in a rare, although probably underestimated condition, which is the constitutional mismatch repair deficiency syndrome, we can have the biallelic mismatch repair gene mutation inherited from both parents with a recessive inheritance modality. Compared to the Lynch syndrome, the constitutional mismatch repair deficiency syndrome has an earlier age of onset, a different spectrum of cancer with a higher incidence of brain tumors. We have more second and third malignancies, so a worse prognosis. But curiously, we also have the presence of non-malignant lesions. If we look at the tumor spectrum of this syndrome, we will see that the majority of patients will have brain tumors, mainly high-grade gliomas, but also supratentorial pinette, medulloblastoma, and others. Then we can have hematologic malignancies, mainly of the T lineage. Then we can also have the Lynch syndrome-associated tumors, and then a miscellaneous of other tumors. The prognosis is very poor in this patient, first of all, because most of them, they have a very aggressive brain tumor. Here we have the number of mutation, and we see that this brain tumor have a much higher number of mutation compared to the other childhood brain tumors, compared to other childhood cancer, and also compared to the adult cancer. So the hypothesis is that after the abrogation of the repair machinery, mutation develop in a rapid burst. Now, for the non-malignant features, these patients show a peculiar cutaneous phenotype, which remind us very much of the neurofibromatosis type 1. 80% of the patients have these café au lait macules, which are slightly different from the macules that we see in the neurofibromatosis 1. because they have irregular border, they can have a variable degree of pigmentation, and typically they have a segmental distribution. Then we can also have hypopigmented maculas, leaf nodule, freckling, neurofibromatosis, neurofibromas, sorry. Other non-malignant features: congenital malformation, agenesis of corpus callosum, cavernomas, and also defects in the immunoglobulin levels. The diagnosis rely on the immunohistochemistry staining, which is diagnostic, and guides the subsequent mutation analysis in the 4-MMR gene. Here in this picture we have an example of a tumor where we have the normal immunostaining for these 3 protein, whereas here we have the negative immunostaining for the PMS2. So in this particular example, the next step will be the sequencing of the PMS2 gene only, not of the 4 genes. So when we suspect this syndrome, for example, because the patient has an early onset gastrointestinal adenocarcinoma, or because we have a childhood cancer associated with NF1 features or with consanguinity in the 2 parents, we have to ask for the immunohistochemistry for the MMR proteins on the tumor sample. Then, if the immunohistochemistry is normal in both tumor and normal tissue, we can reasonably exclude this syndrome. If we have an abnormal immunostaining in tumor tissue, but a normal staining in the normal tissue of the same patient, in this case we will be more oriented on the Lynch syndrome. Whereas if we have abnormal immunostaining in both normal and tumor tissue of the same patient, in this case we are probably facing a constitutional mismatch repair syndrome, and we will move to the sequencing of the gene. Of course, when this syndrome is diagnosed, then the patient will enter a surveillance protocol. So for brain tumors, he should undergo an MRI every 6 to 12 months. Then we move to the rhabdoid tumor predisposition syndrome. Rhabdoid tumors are among the most aggressive human cancer. They are typically diagnosed in infants and children, but can occur at any age and virtually in every anatomic district, although more frequently we have rhabdoid tumors in the CNS and in the kidney. The prognosis is very poor, with only 25% of the patients alive at 5 years following the diagnosis, and it is due to the loss of function of the SMARCB1 gene at chromosome 22. There are some rare cases where the syndrome is related to the inactivation of SMARCA4 gene. These 2 genes, SMARCB1 and SMARCA4, are part of the bigger SNF chromatin remodeling complex, which play a crucial role in the nucleosome remodeling and in the regulation of the transcription. And as we can see in the table, mutation of one of these genes is in many cases responsible for the occurrence of cancer. From the histopathological point of view, rhabdoid tumors may display a combination of cellular elements consisting of undifferentiated small round blue cell, mesenchymal and epithelial components, together with the classic rhabdoid phenotype. But what is important is that when we suspect one of these tumors, the immunohistochemistry for the SMARCB1 has to be done. And here we have an example of the loss of SMARCB1 protein in tumor cells. and retention of expression in the endothelial cells. And actually, I would say that in tumors, in brain tumors, which occur at a very young age and especially in infants, the immunohistochemistry for SMARCB1 should be routinely realized. But SMARCB1 could also be associated to other tumors like epithelioid sarcomas, chordomas, meningiomas, familial schwannomatosis, and many others. Most of SMARCB1 mutations seem to occur de novo, but familial cases have also been reported. The penetrance is incomplete, although quite high, and possible gonadal mosaicism may be present, like, for example, in these two pedigree. Here we have two affected siblings with normal parents, not carrying parents. And here again we have two brothers and sisters with a TRT and normal parents. In these two cases, we could suspect a mechanism of gonadal mosaicism. So when we have the loss of SMARCB1 expression at immunohistochemistry, then we move to the sequencing of the gene on the frozen tissue. But if we don't have the frozen tissue, it can also be done on paraffin-embedded tumor. Then we search, once that we have identified the mutation, we search for the mutation on patient's blood. And if we find a germline mutation, then we have to perform the screening also on parents' blood. In this case, if we identify the same mutation in one of the two parents, we will have an inherited mutation, so the mutation of the child. This means that the child has inherited the mutation from one of the two parents. If parents don't have any mutation, in this case we have either a de novo mutation, either gonadal mosaicism. SMARCB1 is also responsible for familial schwannomatosis, like in this family, where we have two members of the family affected by the schwannomatosis and two children with a TRT. Now, last syndrome is the Gorlin syndrome. Gorlin syndrome is an autosomal dominant genetic disorder with multiple basal cell carcinomas, multiple nevi, palmoplantar pits, odontogenic keratocysts, but also skeletal abnormalities, intracranial ectopic calcification, facial dysmorphism, ovarian fibroma, and medulloblastoma. The tumor that we find in this syndrome is the medulloblastoma. Medulloblastoma is the embryonal malignant tumor of the cerebellum, very aggressive. We can distinguish three histopathological subtypes, which are the classic medulloblastoma, which is also the most frequent variant. We can also have the desmoplastic or nodular medulloblastoma, and the anaplastic subtype. In the last years, 4 distinct molecular variants of medulloblastoma have been identified, and now we are going to focus only on the group where we found a constitutional activation of the sonic hedgehog pathway. This pathway is very important and play a crucial role during the embryogenesis in the development of the CNS and also of the craniofacial structures. But when it is constitutionally activated, it can start the oncogenesis, like in the medulloblastoma. So Gorlin syndrome can be caused by germline mutation in PATCH1 gene or in SUFU gene, which encoded two protein who have a very important role in this pathway. So these genes are two tumor suppressor genes. Gorlin syndrome can have a variable expressivity, and in about 5% of patients with Gorlin, we will find a desmoplastic medulloblastoma or a medulloblastoma with extensive nodularity. These two entities represent around 27% of all the medulloblastomas, but if we look at the patient with less than 3 years of age, we will see that together these two entities reach the 52% of the cases. Here we have to picture, just to say that desmoplastic medulloblastoma are often located in the cerebellar hemispheres, and here we have the typical grape-like appearance of the medulloblastoma with extensive nodularity. Then, take-home message is, in Gorlin patient, we should try to avoid radiotherapy. So, if possible, patients should be treated without radiation therapy or using a treatment field that only includes the posterior fossa. And then, just at the end of my speech, a nice story just to tell you how the cyclopamine was discovered. Cyclopamine is one of the first sonic hedgehog inhibitors. From the name, cyclopamine, just the name reminds us of our scholar years when we used to study Homers and the Odyssey. And when we learned that during his travel and his adventures, Odysseus met Polyphemus the Cyclops. We don't know if Homer has been impressed by the story of a child or someone affected by this cyclopic condition, because this is a real medical condition, which medical name is the holoprosencephaly. So it was not invented by Homers. If we step forward in time and we move to the middle of the 20th century, there was in the United States, in Idaho, in the 50s, an epidemic of cyclopic lumps. Of course, this got the attention of the media, but also of the scientists, who discovered that this epidemic was due to the fact that the pregnant sheep were eating these plants, which has a difficult name, Veratrum californicum, who contained a substance analog of the cyclopamine, who was inhibiting the sonic hedgehog pathway during the embryogenesis, and that's why so many cyclops lamb were born. So from there, then the years have passed by, and this cyclopamine has been further studied, and now we can use the analogs of the cyclopamine and the other available inhibitors of the sonic hedgehog pathway to treat our medulloblastoma patients, like in this case, where we can see the relapse of the medulloblastoma, who progressively disappears with the treatment with the sonic hedgehog inhibitors. Thank you very much.